developing hyperventilation with respiratory alkalosis, and the respiratory rate is going up to 30%. This is the moment to intubate it, in my opinion, and not to delay with other techniques that will add lung injury. When you have this patient ventilated, my advice is to look at the lung compliance. Some of these patients have lung compliance about 60 milliliters per centimeter, so they don't have ARDS at this moment, and these are relatively easy to ventilate. These are patients that can be managed with prostacyclin or nitric oxide, because the main physiopathological mechanism is a severe hypoxemic vasoconstriction. And they don't need prone position at this moment. Recruitment maneuvers have to be forbidden, contraindicated, and this patient has to be managed, in my view, with PEEP under 10. 8 is enough for many of them. If you increase PEEP, you will not have much more recruitment, and you will have hemodynamic instability. These patients are with a negative balance by the hyperpyrexia and the hyperinflammatory state. So you need to avoid to induce hypotension, to avoid to induce iatrogenia with ventilation. If this is maintained, some of these patients will be extubated along the second week between day 10, day 7, and only the patients that will be with ARDS because developed acute lung injury are a problem of long-term management.
This is Phil Berry in New York. We have right now in our institution enterprise-wide 2,100 patients with COVID-19, and approximately 550 of them are on mechanical ventilation, for approximately 25% prevalence of mechanical ventilation among our inpatients. It sounds from Jordi's comments that we are seeing a slightly different and sicker cohort of patients. First of all, I would emphasize that these patients get sick very quickly. They certainly can change hour to hour. In some cases, they can change minute to minute. By the same token, they get better only slowly. We're seeing compliances for the most part in the lung compliances in the high 20s to low 30s, occasionally in the 40s, but our ICU population does not have lung compliance of 60. So all of our patients have very severe acute lung injury, which appears to be mediated by the acute inflammatory reaction cytokine storm that these people experience. Interleukin-6 concentrations are very high, but it's more than just respiratory failure. We are seeing a substantial incidence of acute kidney injury, and I would remind you that patients who do require PEEP more than 10 have to receive fluid in order to maintain their preload. There's been understandable reluctance to give some of these patients the fluid they need. We're doing CVVH for those patients, but because of a shortage of machines, we're only giving patients 8 hours of therapy a day. Also very prominent in these patients is coagulopathy, which manifests itself clinically. We're routinely seeing D-dimers in the several thousands, as high as 30,000. And it's very difficult to keep radial arterial lines patent. It's very difficult to keep VAS caths patent for dialysis. And we are seeing DVTs and PEs. So far, fortunately, we have not had strokes, as has been reported in some cases by our Italian colleagues. We are not seeing a high incidence of myocardial infarction. However, there is also a prominent viral myocarditis component to this syndrome, which makes the interpretation of electrocardiograms and troponin concentrations very challenging. Thank you.
I'd be interested to get a perspective on this question about treatment from Matteo in Italy. Matteo, do you have some comments on treatment specifically?
Could you hear me? Okay. So, you know, I'm not an intensivist, so I don't want to talk too much about ventilation, but it's more regarding the treatment, because actually we are using three different type of treatments. I mean, one is the antiviral or similar to antiviral. The second is the one for inflammation, and the third is the anticoagulant therapy. So I think we have three different settings in this disease, particularly for the more severe cases. So regarding antiviral, so we start using anti-HIV drugs, but then based on the study published in New England about lopinavir, we decide to stop using lopinavir, ritonavir, or any other type of antiretroviral drugs like darunavir. So actually the treatment is based on hydroxychloroquine, so doubling the dose, 400 milligram Q12, plus an antibiotic. In general, we are using a lot of ceftaroline or ceftobiprole because we have seen a lot of cases with superinfection with pneumococcus and staph, similar to flu. So we have in the first cases, particularly in Lombardia, there were a lot of superinfection with staph and streptococcus pneumoniae. So this is regarding the antiviral and the bacterial antiviral treatment. Then we have the second part of the treatment, that is all we are using for the inflammation. So we have had extraordinary effect with high dose cortisone. So actually we use the steroids in any case. So 1 to 1.5 milligram kilo day, and we do this kind of treatment for at least 2 weeks and even longer. We are using also other type of drugs like tocilizumab or anakinra, so that are inhibitors of the IL-6, and we have had fantastic results, particularly with tocilizumab. In many cases, even not in the ICU, but severe cases admitted in internal medicine and infectious disease ward. And then we have seen a lot of problems, particularly in patients in the ICU, but even outside of the ICU, for problem with thromboembolic diseases. And this is the reason why we are using anticoagulant in all the patients since the admissions in the emergency room. So it is a kind of different way of using the drugs. I mean, we can talk about three separate situations. So this is at least based on the Italian experience.
Thank you very much, Matthew. Tobias, could you give a perspective from Germany, please?
Yes, I start with mechanical ventilation. So I think what from a pathophysiological point of view is typical for COVID is the first phase of the severe COVID disease is driven by Th1 lymphocytes, and lymphopenia is one of the main symptoms of the COVID disease. It's a capillaritis. It looks like an autoimmune disease, and capillary leakage is the main problem. This is the reason why prone position is so successful, because extravascular lung water is the main pathophysiological driver. In the second phase of COVID disease, it's more a classical RDS picture, and this appears about 5 to 7 days after intubation. And then it's neutrophilic driven, and pathophysiologically it looks like classical RDS. I agree with Phil's comment. Normally, if patients improve, you see a second wave of inflammation after 5 days, a kind of hyperinflammatory syndrome. So in my patients, it's about 10 to 20% of patients who suffer from this. With regard to medical treatment, we are more cautious in Germany. So looking to the Chinese data, patients were treated with 10 different treatment regimen, and altogether, finally, you do not know what happened. I'm a scientist. I'm not in favor of this. So in Germany, we tried to include all patients in randomized controlled trials. And we now have trials which are run by the German Center of Lung Research and the German Center of Infectious Disease Research. We have trials for hydroxychloroquine, for remdesivir, and we are part of pharmaceutical trials, for example, anti-IL-6 or anakinra, which is anti-IL-1. There are a number of new treatment options coming up using mRNAs or something else as phase 2. But again, the German approach is not to treat patients outside from clinical studies. Coming back to my patients, in my hospital now, 8 patients had left the intensive care unit and returned to home, and all this had not been treated with any pharmacological treatment. So there is a self-limiting property of the disease, and it's always the same. I agree with, I think Jordi said it, if you start oxygenation and adequate ventilation too late, this is very bad for prognosis.
Tobias, thank you very much. Stay on the line, please. I have a question which has come through, which I'll put to Tobias in the first instance, but it would be good to get a view from others as well. Just a reminder to anyone that's online, may have joined in partway through the meeting. We are recording this meeting. There will be availability for this, for you to view this afterwards and to share this more widely. So in response to that, can I also just remind everyone as well that if you have a question, please go to the Q&A section and submit the question there, and you can vote on questions that are already on there, and we can then get the most important questions, or the most popular questions at least, to the top of the screen. So right at the top of the screen right now, Tobias, we have a question. Can you please comment on performing bronchoscopy on cancer suspect patients? Would you have a view on that, Tobias?
Well, that's a very complex to answer question. First, the corona disease has 2 stages. The first stage is infection of the upper airways, and during this phase, nasal swabs are a good diagnostic tool to diagnose the infection. In the second phase, after 5 to 7 days, the virus is down in the lower airways, and at this stage, 30 to 40% of the patients are nasal swab negative. Then you need a lower airway specimen. You can perform bronchoscopy, but you need to be protective. This means we do it by using FFP2 masks and protection glasses. What is a very good diagnostic tool for COVID disease is CT scan. The pathology in the CT scan with peripheral consolidations is very pathognomonic for COVID disease. And if you have clinical signs and symptoms and a CT scan, the sensitivity of diagnosis is about 97%. So this is what we do. A patient coming in with a suspicious of COVID disease, we start CT scan, and if this is positive, and if this is typical, yes, we perform a diagnostic test, but we treat these patients like COVID patients.
Tobias, this is Phil in New York City. With respect to your comment about upwards of 40% of patients with predominantly lower respiratory tract disease testing negative, what would be your opinion as to the veracity of the testing that you're performing? Our hospital is telling us that the accuracy rate may be as low as 65 to 70%. So are you dealing with a cohort of patients who are false negative?
Well, I think the currently available PCR tests, so we use the Roche test, but you have different on the market. They are as they are. It's a question of the quality of the specimen.
Yes,
and a question of the stage of disease. And as I said, in between the first 5 to 7 days, it's an upper airway disease, and then it's descending. And if it is in the more severe cases, so the cases which come in and go to intensive care unit, the intensive care unit immediately, the upper airways very often are cleaned, so you have no chance to get a positive test by nasal swab. So for this reason, in the intensive care unit, we perform bronchoscopy using the protective measures. We also do it because we use the BAL for research reasons, but normally, CT scan is very, very accurate in diagnosing COVID. So if the CT scan is typical, you have to treat it like a COVID disease.
Peter, if I can say here, I think there are two things at play, and it's very important that we're clear about them. What Phil's talking about initially is the sensitivity and specificity of the actual detection of the virus. And the first thing to say is that none of the tests that we're presently using have gone through the normal validation processes. The figures that you're quoting, Phil, of about 65-70% sensitivity, they are correct. So that's if the virus is present. Some of the tests that are being used only stand about a 70% chance of getting it. What Tobias is pointing out, and it's very important, is understanding the phasing of the disease. So that initially in the early stages, the first 5 to 7 days, you find it in the upper respiratory tract, the nasal specimen. But then as the disease progresses, you find it in the lower respiratory tract, and you need to test the right place. When you test it, it's then back to the sensitivity and specificity of the actual viral detection that's going on. So it's the two things. It's how good the test is, and it's recognizing where you need to test and when.
Okay. Well, that's
one additional comment. When we started testing, and I think Germany is one of the countries with most of tests per population had been done, we started with throat swabs. And this is nothing to recommend, because if you do it, patients cough, and this is difficult from a protective issue for your staff. So we changed from throat swab to nasal swabs, which is much better in terms of patients coughing and aerosol production.
Thank you, Tobias. Can we go to Professor Marion Colliff? Marion, we've tried to stay kind of quite close to this question about treatment. I also have a question to put to you about respirators as well, but let me first of all ask you to give us perspective on the treatment aspects.
And then I'd like to follow up with a question for both Maren and Tobias.
Absolutely fine. Thank you, Phil. Okay. We've lost your sound. Oh, it's okay. You're back. Carry on, Maren. It's fine.
Yeah. So what is the question?
Specifically about treatment in ICU, COVID-19. The choice of treatments.
I guess I'm not hearing the question.
Okay. Can you hear me okay?
Yeah, I can hear you now.
Okay. All right. Okay. So the main thing that the Mexican attendees said they wanted to hear about was treatment of how you're treating these patients and in your case in intensive care.
Yeah, so I mean, what we're doing in the ICU, and obviously Phil and Tobias and Matteo have had more experience than we have at this point, although our numbers are ramping up. We're on the steep portion of the curve right now. I mean, we're basically focusing on just allocating our ICUs, and we're opening up all our ICUs currently, including our ORs for patients that are coming in now. And we're really focusing on early intubation. And that's the thing that we've been really looking at, and very similar to the other comments that have been made. We're using thresholds of high flow oxygen, anyone that's above 6 liters, 7 liters, 8 liters. We have a pretty low threshold for intubating those individuals, and we use rapid sequence intubation. And, you know, the initial problems that we got into with mechanical ventilation were ones where some of the clinicians wanted to treat these patients like typical ARDS with high PEEP, but we found very quickly that that really didn't work. And so what we're focused more on is keeping a moderate level of PEEP, usually somewhere around 10 centimeters of water, and using the FiO2 appropriately. And we've had some problems with using, for example, inhaled aerosolized treatments, Flolan and Belitri specifically, and we're avoiding their use in patients who have severe disease, who aren't responding to proning, and are on occasion using nitric oxide in patients, and even considering the use of ECMO in selected individuals. But the vast majority of the patients that we've had to date that have recovered, and that number is in the range of about 15, have not required ECMO, have just required the typical conservative measures where proning seems to be very helpful. We are trying to get patients on protocols. Anecdotally, there have been a couple of patients who had very dramatic responses to tocilizumab. But again, I can't tell you if that drug really works. We have to wait for the results of the clinical trial.
All right, thank you. I'm going to go back to Phil, because Phil, you have a question you wanted to direct to Maren and possibly to Tobias.
And Tobias. Tobias, your comments were very helpful. I'm interested in the comment that you made about the frequent use of bronchoscopy, presumably both for diagnosis and pulmonary toilet. At our institution, we have been doing almost no bronchoscopy because of the high potential for aerosolization and the risk not only to the environment, but also to the caregivers at the bedside. So we're doing almost no bronchoscopy. And I'm wondering why your opinion might differ, and I'm certainly very interested in hearing about this from Maren, who probably knows as much about bronchoscopy as the rest of us combined.
Well, I can tell you we are now dealing with COVID for about 5 weeks, and I've seen around 100 or more patients, and we had not one nosocomial infection of the staff by fulfilling a strict protection strategy. And we do it not for secretion management, because secretion is not a real reason. We do it for diagnostic purposes, because in the late phase the nasal swab is so bad, and we had a lot of experience with negative patients in classical diagnosis which had been positive with, let me say, BAL, or also mini BAL or tracheal aspirate. But that's a reason why we do it. But I'm on the same lane than I think Marin or you, Phil, are. We do not use aerosolized medication in any way. So this is something we totally avoid.
Marin?
I have to go to the ICU. We're going to intubate someone, so I'm going to sign out.
Thank you, Marin, for joining us. That's understandable. Okay, thank you very much, Tobias, for your response. We have a question here. Top of our list, actually, on the screen at the moment is, what is the true usefulness of N95 respirators? And how do we optimize their use moderately, freer of contagion?
Can you pick that one up, Pete, if I come in?
Indeed, yes, Bob.
Okay, again, we're learning as we go along with it. In high-risk situations, the two masks that are recommended for use are the FFP2, which is the N95, and then the FFP3. In the UK, we are tending to use the FFP3. Each of them have a capacity and a performance that should make them safe in terms of inhalation risk. But inhalation risk is only one of the risks that you're dealing with in the aerosolized environment. You also run the risk of mucous membrane involvement, so eye protection is important. You run the risk of contamination of clothing. So again, gowning up where you're doing a significant aerosolized procedure is recommended. Gloves are recommended. So masks are one thing, but you need to look at them as part of an overall PPE program. The other thing about the masks, and this applies more to the FFP3 than the FFP2, the N95, is face fit. Because without appropriate face fit, then they don't work. Face fit is quite a procedure to do. It's done using testing with aromatic substances where I work. The other problem that we have come across with particularly the FFP3 is we were using it in ICU staff where they were having to wear it for prolonged periods of time. And we actually had people who were suffering from bruising around their nose and face from wearing the mask for a prolonged period of time, whilst trying to work, speaking to other people and dealing with other things. So using FFP2 and FFP3 masks, the guidance now in the United Kingdom is that they should be reserved for high-risk procedures as part of a full package of PPE deployment. In low-risk procedures, we are now going back to traditional surgical masks, but again, advising on the fit, and again, using them with other PPE protections, such as particularly gloves and facial protection.
Thank you very much.
Yeah, same in Germany. With one exception, we only use FFP2 masks. We do not use FFP3 masks. And we do it like Bob had said, so in high-risk procedures, which is intubation, bronchoscopy, ear-nose surgery, teeth and other face surgeries. These are the high-risk procedures. And on the normal ward, we are back to surgical masks. As Bob said, so we have masks for patients and masks for the staff. So I call it a double mask procedure, and we do the same as Bob said in terms of glasses, gloves, and other protection measurements.
Yeah, Tobias, I think that's a really important point, talking about the patient, because we've been recommending the same thing. And although there's no evidence about it, I would suspect you get better protection from putting the mask on the patient than the healthcare professional using it.
Yeah. We use it in all patients. And well, I only can tell you what happens after 5 weeks. So our nosocomial infection rate is very, very low, but we are controlling it very deeply.
This is Phil. I agree in principle with both Tobias's and Bob's comments. But my environment is a bit different. We are doing emergency operations on COVID positive patients, and I am attending in an intensive care unit that has 20 COVID positive patients, all of whom are on ventilators. So I am working in a cloud of COVID, and so I am wearing an N95 mask at all times.
Yeah, I think, Phil, you're making a very important point. Again, going back to the original Chinese experience, some 40% of the initial cases in China were healthcare staff. In the United Kingdom, even employing what we consider to be appropriate measures, we have had 4 deaths from doctors, 2 deaths of nurses involved in COVID-19 patient care. So Tobias's experience is greatly to be applauded, but I think we all need to recognize that there are significant risks for healthcare staff exposed to COVID patients, and using PPE is essential, in my opinion. Some of the reasoning behind what we are doing in the United Kingdom is actually driven by availability. So we would like to use the FFP2 masks, FFP3 masks more, but we don't have enough of them. So it has to be a risk-based approach, and that's fine just now, but if we could ramp it up, we would. So if you
to amplify Bob's point, we have to keep the frontline caregivers healthy. We also have had deaths of frontline caregivers in New York. Right now at my institution, 50% of our respiratory therapists are out sick, which limits greatly our ability to use advanced mechanical ventilation techniques in the sickest of the sick patients, who end up in the intensive care unit. If we don't see to the safety of our frontline healthcare workers, the system, in my opinion, would be in danger of collapse.
Thank you, Phil.
I agree totally. So staff is essential. So in Germany, where we have a lot of resources in terms of hospital beds and intensive care beds, and we also have no problems with the number of ventilators, but the main limiting factor is the number of staff. So protection of staff is our major issue.
So if I can add, obviously when I talk about the treatment in my country, we are all using antibiotics in randomized clinical trials. So this is important to know. Actually, there are more than 25 randomized clinical trials run by the IFA. So, and we are all using the different drugs in randomized clinical trials. So we will see our results, I hope, soon. We start using also remdesivir in an expanded access program approved by Gilead. And we started using just last week also a new randomized trial on favipiravir, that is a new antiviral treatment from Japan. So this is an adjunctive trial, so versus placebo. So we are going to see the results soon. But another important consideration regarding the healthcare workers, I fully agree that we have to wear the N95, but the so high number of cases in healthcare workers are also probably related to the prevalence of the disease outside of the hospital. So we have now data from Lombardia that the prevalence in some region, in some small town, is more than 30% of the population. 30% of the population. So we test with the serology, and there are not obviously Milano, but Codogno, for instance, or many other small towns, there is a very, very high prevalence. So it is very difficult to know where the healthcare workers were infected. Because if there is 1 people over 3 outside of the hospital that is already infected by the virus, it's not easy to understand if the healthcare workers get the infection inside of the hospital or outside of the hospital. So I believe that actually for the situation that you have in Italy, in many cities, probably healthcare workers must wear the mask, not only inside of the hospital, but even probably outside of the hospital. So this is a consideration that we are doing now in my country, because there is a high circulation of the virus even outside of the hospital.
Thank you, Matthew. I want to stay with treatment. And also specific infection. We have a question which has been asked: do we have recommendations for perinatal infection? Who would like to respond to that?
For what, sorry?
Perinatal infection.
So actually, we have the experience in my hospital. We have already more than 25 deliveries, and none of the newborn were infected. But this is our small experience. I know that in England, there has been probably one newborn that was infected, but our experience was probably very lucky. So 25 delivery in the past 3 weeks from COVID positive pregnant women, and none of them were infected.
In New York City, the prevalence in pediatric units is much lower than in adult units. I can't speak to neonatology specifically and the perinatal experience, but our pediatric intensive care units are not taking care of nearly as much SARS-CoV-2 related disease as are the adult units. I don't know whether the children are indemnified in some way that we have yet to ascertain.
Well, my experience is a little bit different. So we have a newborn who are positive for COVID-19 when the mother is positive, but they are not ill. So they have the virus, but we do not have one newborn or one young child which is really severely ill. My explanation is, as I said in the beginning, this is a Th1 disease, and it's the mass of Th1 lymphocytes which accumulate in the lung, and the Th1 response in newborns and young children is much less than in adults. So it's the pathophysiology of the virus is in a way that the innate immune system of young children is not affected.
Tobias,
my experience with kids is that obviously it is reported everywhere. The incidence of pneumonia is very low, but the kids that are being accepted to the ICU typically have co-infections. I was aware of a young teenager that died by a super infection with a meningococcal sepsis, and others are kids that have chronic conditions that presents acute decompensation. So it's not the same presentation that in adults that is mainly a lung problem.
What about plasma infusions, Jordi? Any comments on that? We had a question along those lines.
What about?
Plasma infusion in newborns?
Well, I know that it has been tested in a few patients and convalescent plasma, and they have presented a good response, but I don't believe that this would be a strategy that would be implemented for 1,000 of people that is coming to the hospital.
There is a special problem with reconvalescent plasma, and this is that the antibody response to COVID disease is not a strong one. It's late, so the antibody raises about 4 to 6 weeks after you are healthy again, and it's not very strong. And if you want to use antibodies for passive immunization, you need, for example, an antibody titer around 1 to 640. Neutralizing antibodies, and I had access to the Wuhan data, and it's only about 5% of the reconvalescents which have such high antibody titers. So if it if you may use it in the future, it's only a minority of those who are healthy again, which are usable. And altogether, with all the experience, passive immunization is not a new treatment option. It has been done from Spanish flu on. It has never been really successful. My problem with the Chinese data, they are optimistic with everything. And there are now hundreds of papers around, always positive. However, these are study designs. If it is not COVID and if it is not our days, such kind of studies never would be accepted for publication.
In New York City.
What is, sorry, Tobias, your experience with, what about low cyclosporin in low doses?
If we could just stay on the plasma transfusion issue for one more moment.
Yep.
In New York City, we have a large-scale multi-center clinical trial ongoing managed by the New York Blood Center that has 24 participating hospitals. So hopefully we will be able to continue contribute meaningfully into this discussion. You know, I agree with Tobias about the weak antibody response in these patients. Plus, we are relatively early in the disease process in that my intensive care unit admitted its first patient only 9 days ago after the medical intensive care units filled to overflowing. So we're only about 2 weeks into the really bad phase of the disease here. We do not have a lot of convalescent patients. So there is not going to be a lot of convalescent plasma around in New York City for quite some time. And because of the weak antibody response, potential donors are being put through a very stringent screening program in order to ascertain their suitability before plasma is collected from them. Plus, I don't believe we have any idea yet what the dose is going to be.
Interesting.
Totally agree. So, yeah, with regard to cyclosporin, that's a very interesting question. And it's not only cyclosporin, it's also mycophenolate, because for both, for MMF and cyclosporin, there are cell culture data, not with corona SARS-2 virus, but with corona SARS-1 and the MERS virus, which showed an efficiency. However, it has not been used in clinical trials now in COVID-19 patients. What is of interest, and I also have access to the Italian data, is that if you look to solid organ transplanted patients, it's astonishing that the number of these patients who are severely infected and admitted to the ICU is surprisingly low, which could mean that there is something which is protective. But looking to the study portfolio at the moment worldwide, cyclosporin is not in.
Thank you, Tobias. Before we proceed any further, I would just like to, we've got about 15, well, actually just over 10 minutes left. So we focused a lot on treatment, which is what Mexican attendees said would most like to hear about. So I'm pleased with that. I just want to get a comment from Dr. Gerardo Martinez. Gerardo, from what you've heard so far, do you have any major question that you'd like to ask the rest of the international panel? Gerardo.
Okay.
Yep.
Yes. I think a lot of, almost all of the question has been answered. I was looking in the chat and there are some questions about protection, about using the correct use of the mask. So I don't know if it is possible to speak a little more about that. And
yes, so with the questions we have, obviously we've addressed the question about the N95 mask. Was there a specific question around protection that you wanted to put to the panel, Gerardo? I was thinking we should probably spend the last 10 minutes focusing on prevention. We've spoken a lot about treatment, but maybe what can we do before we get to that stage? But if there's a specific question around the masks that you want to ask, then by all means.
It's about the duration. How long can you, is the mask efficient for protection?
Okay, how long is a mask efficient for protection? Bob, could you answer that one?
Yep, and I'll address it in terms of the FFP2 mask, which is the N95. It's the one that's most commonly used. That mask will provide protection for several hours. The important feature about breaching the protection is if you fail to get a good fit, that one you don't need to do the aromatic face fit test for. That's the FFP3. The FFP2, however, it is important you still fit both over the nose and to the cheeks. And where it starts to go wrong is once it becomes moist. So if you're using it on somebody who's coughing, what Tobias was talking about earlier on, and the mask becomes moist, then that breaches its integrity. So it's not really a length of time that you need to think of, it's the environment it's being used in, but it is protected for several hours. They are supposed to be single use only, so if you have them on for a shift, you're supposed to take it off and then dispose it and use a new one. But again, with restrictions on the availability of PPE, I am aware of some colleagues who are using them effectively for a day. I don't recommend that. I recommend that they're single use and then discarded and replaced.
Thank you, Bob. Okay,
it's a little bit. So I cannot agree more. It's a little bit a question of availability. So if you have shortness of masks, and this is a problem worldwide and had been a big problem in Italy, you have to figure out what you can do to prolong the life of the mask. So Bob is right, but if you have nothing, you have to think a little bit more liberal.
We also have to bear in mind that we're not all alike in terms of our comfort level with wearing masks. Surgeons do it day in and day out. There are some specialties where it would be never at all. And certainly our other frontline colleagues in nursing, wear them only from time to time. The people who are managing the logistics, perhaps never at all. So one of the things that we've done in our institution is we have produced video series and webinars for our staff in the proper donning and removal of PPE. I would recommend that very much to all of you.
Thank you, Phil. Okay, I want to get this next question in before we finish. We've still got a lot of questions to get through. In the summary at the end of this meeting, I'll be explaining to you all how you can get answers to those questions after this meeting is finished. But let's try and finish. We have a question here on the screen, which I think is a really good question. And it's asking about, in the experience of those countries that have already passed phases 2 of the pandemic, what are the key strategies to avoid contagion for health personnel? For example, who receives a patient? Who takes a sample? Who does the intubation? And who is at their disposal to take care of that? So maybe I've put that to everyone on the panel. Preventing contagion with healthcare personnel.
So in the case of intubation, we try to do that in a negative pressure room insofar as possible. That luxury is rapidly going away as the number of patients increase. But for intubation, there are only 3 people allowed in the room. The anesthesiologist, the primary nurse caregiver, and the respiratory therapist. 3 people in the room with the patient.
Jordy, any comment?
You are muted, Jordy.
Lower left.
Well, I was saying that our system is different. We don't have respiratory therapists, and these tasks are conducted by nurses. And certainly this is a very high risk procedure.
Oh.
And what is a rule is that the person that has more experience is the person that has to do the procedure. And we usually use video laryngoscopes that are managed by expert anesthesiologists. And if they are available, this is who is conducting the procedure. And we are limiting all maneuvers in using aerosols. I think that CPR has not very sense in a patient with a very terminal state with PACIENTE under 100 by a disease that don't have a specific management, and we are lack of ventilators. I believe that the tracheostomies have to be limited. There are some people that is doing. I discussed this with my colleagues in Italy. Personally, I believe that the weaning have to be done not in the tube. The weaning has to be done with a pressure support of 7, just to protect from contamination, because what we learned from China is that the shedding of these patients is prolonged a medium of 23 days, and bronchoscopies are not performed at all.
And I would add, Jordi, that our experience is that extubation is challenging in these patients. They may meet criteria very well, but many of them struggle. And there is an incidence of reintubation in these patients. So not only is it difficult to manage these patients, but the prospect of sometimes an urgent reintubation poses risk to patients and staff.
Yes, you are right.
That's the reason.
The complication is that many of them have a psychotic presentation, probably induced by chloroquine or some of these drugs, and it is a big problem for management.
Nice, you were going to add?
That's the reason why we perform early tracheostomy.
Oh, interesting.
Because it makes the handling later on much easier. And if you do the tracheostomy with best protection rules, it's safe for everybody. And then we are much safer in terms of the weaning process. So it's much easier.
We have
Of course, we have the same experience.
Probably
you formed a tracheostomy team to minimize the number of people who are doing it.
But the experience in countries like Mexico is that most of them died when transferred to the war. So it has to be very restricted, in my opinion.
In the United Kingdom,
Paul Bassington, please, if we could just turn it on.
Yeah, in the United Kingdom, I'd like to come at this from a slightly different direction. We're talking about suppression, we're talking about protecting staff. In the UK, we've changed our strategic approach to COVID as we went along. Initially, we were going for effectively a containment approach, looking to get a degree of herd immunity. But then what came out of Imperial College that predicted a death number in the UK that was so large that it was politically and socially unacceptable. And then the effort became about maximum disease suppression. So like in Italy, we've gone on to lockdown. The difference between us and Italy is that we've gone on to lockdown earlier. And one of the ways that that is being sold to our public is, and I'm quoting now from the adverts that are on the telly, save the NHS, stay at home. Because what we do not want to do is to find ourselves in the situation that Matteo was describing, where you've got such a large element of your population in the community involved with COVID-19, that all the PPE and infection control you provide to your healthcare staff in hospital is effectively irrelevant because they're going to get it in the community. So what we're saying to our population now is, let's stop COVID spreading in the community to protect the NHS staff, the healthcare staff in the hospitals at the front line, where there the infection control measures will then be appropriate. Now, I appreciate that for Mexico, like for us here, that was a government decision. That's not something as clinicians we can do, but it is something that we can influence, and I would encourage you to do that through your local government mechanisms.
Okay, Bob, thank you. We are just about out of time, and I want to respond to a question that I'm sure everyone on the call has got, and that is, how do we answer all these other questions that we've not had time to cover today? We will answer those questions, and we will make those questions available to everyone who's joined the call today. As you know, when you joined, you had to register. So we will contact you via that email address or to make it available online so you can come back. Just give it a few days. We have a lot of questions there that we've not really even touched on so far. But you said at the beginning of the call the Mexican audience wanted to hear a lot about the treatment. We tried to focus a conversation around that. I think we've had some other good discussions around prevention, the type of mask, the intubation, some specific patient types as well. I hope it's been very useful for you. And as we say, anyone that didn't make it today, we can make the video available so it can be shared with a wider audience. I just want to, we have over 40 questions still, so we have plenty to come back to you on. I would like to just ask Leslie Robertson to mention the final poll, which we'd like you to do, please, Leslie.
Yeah, what I've done is I have released again onto your phones some final polls. Really, it's important for Pete and the team to know whether you found this valuable and whether it's been a very useful experience. Some very simple polls. We're not going to show them to screen. Tell us exactly what you want. And we've added something that if there's any other comments that you have for the panel, for Pete, or for the association, just pop them on. Really appreciate it if you take 30 seconds to click 2 or 3 buttons and tell us how it was for you. Thank you.
Yeah, so in terms of closing remarks, then Leslie, first of all, I want to thank again the international panel from AIM for your contributions, for making yourselves available at very short notice to help share some of our experiences with our Mexican colleagues. Thank you so much for that. Thank you very much for Dr. Gerardo Martinez in particular for helping to facilitate this meeting at short notice with us. And a big thank you to Leslie Robertson and the team from Open Audience who've provided us with this excellent platform, which has allowed a lot of open discussion and engagement. May I finish by wishing you and your loved ones and your patients all the very best, and we'll be back in touch again with further information about today's teleconference. Thank you, and have a lovely weekend. Goodbye.
Thank you, Pete, and thank you for bringing this together.
Yes,
Bye-bye.
Bye-bye.
Thank you. Thank you.